Morning, everyone.
Morning.
Good
Morning.
morning. Good morning. Okay, so I want to make sure as best as we can, that we are like in consideration of everybody's time. So I would typically be like, hey, let's wait a couple minutes. So everybody can hop on here. But again, I want to be, conscious of you guys' time. So let's see, the meeting is recording. Okay, perfect. So we would just go ahead and get started. So my name is Khadijah Simmons. I'm a behavioral health care manager at UAMS and I love it. And my task today is to introduce some pretty awesome people. Their bios are great. And that kind of led me into doing my own little deep dive. I went off on a full tangent, just so I can know more about them. And so I just want to share a little bit about them before they come before you guys and share all of their goodness that they want to share on today. So first, we have Dr. Jeff Reiter, and I hope I'm pronouncing your name correctly. He is an internationally recognized expert in the integration of behavioral health into primary care. Since 2002, he has worked in integrated care as a clinician, administrator, trainer, and consultant in the community health, commercial, and government healthcare sectors. He has helped hundreds of primary care systems, clinics, and individuals in their integration efforts, both throughout the U.S. and internationally, publishes and speaks regularly on the topic of integration, and is on the faculty of Arizona State University's Integrated Care Training Program. Dr. Reeder has received numerous awards and advised many organizations through board and advisory committee membership. He is co-authored with our other speaker, Dr. Patricia, three of the leading how-to books on integrated care. And then, of course, Dr. Robinson is currently the president of Mountain View Consulting Group, a winner of an APA Presidential Innovative Practice Award. In 2023, she received the Don Block Award for Excellence in Integrated Care, and in 2024, the Primary Care Luminary Award. Dr. Robinson is co-founder of the Primary Care Behavioral Health Model and co-founder of Focused Acceptance and Commitment Therapy. She provides consultation and training services internationally and is committed to improving access to healthcare services, as well as the realization of health equity. Early in her career, she worked as a researcher and clinician for Group Health Cooperative in Seattle, Washington, and as a behavioral health consultant for Yakima Valley Farm Workers Clinic in Washington also. She has authored many articles, books, chapters, and books in total. With Dr. Jeff Reeder, she published the third edition of Behavioral Consultation in Primary Care, a guide to integrating services this year in March 2025. She lives in the Willamette Valley of Oregon with her partner and their puggles, which I thought was so cute, Mac and Molly. So you guys take the floor.
Oh, thank you so much for such a warm introduction. It's just a joy to be with everybody on the call, and I see lots of people are coming on. Jeff and I just want to kind of it's like taking your baby out when they're old enough to go out. And so the book was, I think it shipped on March 17th or something like that. So official birth date back in March. But we want to tell you about it. We think it's really a great contribution, and we want to point out some of the things that might be helpful to you and want to keep it really interactive. So please do type into the chat, whatever questions, comments, thoughts you might have, and feel free just to unmute yourself and speak up too. Um, let's see, I'm going to switch and share some slides just so you have a visual uh, reference. Oh, I had to put this in first. I just uh, only read it yesterday, and I said, "Oh, I got to put this in." But some of you may know I've been working with the country of New Zealand over the past 7.5, almost 8 years, as they've kind of put their foot in the water, and then with primary care behavioral health, and then then decided to scale up and support primary care behavioral health as a service to all of their citizens on both islands. And this is the latest review, and it's from the South Island of New Zealand. And it's an update from the 2023 review, where this is just a countrywide service. And it is now reaching 76% of the enrolled population. So 51 of 76 practices, including a lot of rural communities, have PCBH services in to May 2025. The service supported nearly 20,000 people, equivalent to 7.7% of those eligible. The national target is 6.5%. So 84% of clients are seen in within 1 week, and 62% are seen on the same day, uh, uh, surpassing again national expectations. When we look at Maori and Pacifica populations, strong equity there with both groups enjoying higher rates of access than the overall population, which is the intention in New Zealand. So productivity up, and all of they call themselves health improvement practitioners rather than behavioral health consultants, but all are trained in focused acceptance and commitment therapy prior to stepping foot into their clinics or practices, and all have the practice habits of using metrics to inform their service. So they have ratings like helpfulness of a visit and confidence in following the well-being plan developed in a visit. And so you can see that the helpfulness 9.1 out of 10 and 8.7 in confidence. So really nice metrics to see about every visit. Um, they now have manuals that kind of describe the competencies of primary care providers and nurses and all the other people on the team. They have 3 copies of these short, focused manuals, all based on the third edition of the book in all of their practices on the South Island. So progressing along, there's a QR code where you can get more details on this evaluation if you're interested. But I thought, what a great way to quickly say, hey, people are reading this book and they're they're doing this stuff, and it's working for the people, which is what we want. Um, so yeah, the first book that Jeff and I wrote, the first edition was purple, and Jeff and I said, "Oh my God, you know, we didn't even get a choice. We worked so hard on this book, and we didn't even get a choice. We got this wonky cover, and turns out, we didn't get a choice on the second, and it was blue, and then turns out no choice on the third." Um, but it's purple and blue. And so we call it the purple and blue book, hence the slide background. Uh, we wanted to just walk you through the different parts of the book. So the first part is all about the potential of primary care, which is something so important to keep in mind right now. The potential is so strong, and we need to believe it and support it more than ever. Then we have a chapter on just a primer on primary care. All of these things very updated. Jeff, want to say a few words about the chapter 1? Just huge resource in terms of references. Any of you interested in going for funding for a program evaluation study, a grant, a great resource for the latest and most up-to-date uh, references.
Yes, I would say, and hi everybody. Thanks for having us here. Um, And yeah, as far as chapter one goes, I mean, the reason we put updated there in that in the title of it is because we've actually had a similar first chapter in both of the previous editions of the book too. And so each time we do a new edition of the book, it's really just it's kind of making the same case for integrated care and has the same goal of kind of setting up in particular why this particular way of integrating, can be so important and helpful. But we update it each time with, new literature that's come out since the previous version and kind of new evolved, understandings of the model and that sort of a thing. So yeah, uh, that was a long chapter to write. Like Patty said, it's got a ton of references in it. So, but hopefully it, would prove helpful for any of you who are um, kind of looking for that background material on, you know, just thinking about why are we doing this exactly and what is PCBH again, right? Which I actually think you're never too experienced to revisit that because I think the more that you you reflect on and understand why this type of integration is important to do, the more it makes sense why we're doing it, right? If you if somebody's just asking you to see more patients in less time, right? Like you're used to having an hour-long visit for everybody and seeing maybe, five people a day, and suddenly you're seeing people in 30 minutes or less and seeing, twice as many people as that per day, a lot of whom just get walked into your schedule, without any prior warning. It's like, wait, why am I doing this again? Because this is harder than what I was doing before. And so I think, just kind of any chance you have to revisit why it is that it's so important that we practice in these different ways, just helps, at least it helps me, to kind of keep my excitement for doing this work fresh. So that's what the first chapter is about.
Yeah, and I'll just say we put a pre-publication copy of that chapter on the website, the book website. So the book website is the title of the book with .com behind it. But the other way to get to the book website that's very easy to remember is speaktoyourdoctor.com. It's just that phrase, speaktoyourdoctor.com. If you go there, you'll see the book website. And if you go to the tab that says Speak to Your Doctor, then underneath that, you'll see that chapter. And we wanted to put that chapter there because we're hoping, and this is kind of at the end of the talk, we'll mention this more, but we have a bit of a um, campaign to increase integrated behavioral health services in our communities because most people don't have them yet. A lot of people do, and it's growing. But we want to encourage a conversation between you and me people, your neighbor, your daughter, your mother, and their primary care provider, a conversation about integrated care. And so we have a tip sheet there for what they might say. And we'll share that with you a little bit later. But one of the things they can do is they can share this chapter with their doctor and say, hey, ever thought about this if they don't have an integrated behavioral health service in their clinic? So part two, the new primary care team is something I'm very, very excited about because we have new core competency tools and they include behavioral anchors, lots of scripts and phrases, and it really increases the consistency in training and the consistency in performance among people trained to deliver this service. So, like in New Zealand, we've now trained over 500 behavioral health consultants. And we have a group of about 35 trainers, and they love the core competency tool for behavioral health consultants because it provides a lot of richness. And the person that's learning this role doesn't have to remember it. They can go, they can self-evaluate, they can target, develop learning plans. So both of our core competency tools are available on the book website. So, again, have a look at those. The digital versions there are such that you can just type into them. You don't have to print them out. In the book, you'll find we have a briefer version that you can print out as well. That's available as well. So it's all about knowing what you're doing and being consistent. That's really important, I think. And from there, you could do a lot of adapting to your clinic, your population. And by the way, the core competency tool for the team, this is also for medical assistants, community health workers, behavioral health care managers. This is how the team works together and the ways that they support the work of the team. Um, so I am involved increasingly in teaching fact to behavioral health care managers and health coaches, and we're getting data on how this can help us increase our reach and extend the reach of the primary care integrated team into the community. So these are our dedications, and I dedicate to my twins that are 2.5 now, Mina and Iona, and to my grandson Rylan, who's well, he's turned 15 now. But it's all about what we want for everybody. May you be healthy. May you be respected. When you ask for help, may there be somebody there. May you experience a sense of caring all your life. And Jeff,
And yes, I dedicated mine to Patty and Kirk, Kirk Strassel, Patty's partner, um, as well as Judy Featherstone, who was the chief medical officer who hired me for my first integrated care position way back when, and then all the primary care heroes. Because one of my big, talking points is that primary care providers are really the heroes of the healthcare system. It's the most important part of healthcare, if you ask me. But it's also one of the hardest parts of healthcare. So, um, like I'm guessing is true for all of you, it's an amazing place to work, right? We get challenged every day, but incredible opportunities to also get inspired and learn from folks. So.
so I somehow or another, the slides are a little bit jumbled. I'll come back to that. Ah, do you know what the other chapters that I wanted to put in here, Jeff? I'm gonna let you talk for a second, and I'll just put these in. Why
Yeah,
don't you
I
talk?
can just mention we had a little chat going on in the in the chat box there while you were talking that I was asking if anybody you had mentioned the whole speak to your doctor thing, and I was asking if anybody knows what percentage of PCPs in the country have integrated care in their clinic, and it's about 19% of PCPs have some sort of integrated care. It doesn't mean they're doing PCBH specifically, right? They could be doing collaborative care model. It could be, have more of a co-located therapy model, but um, around about 19%. It's a lot higher for FQHCs. It's somewhere around 90% of FQHCs, but have some sort of integrated care. But in general, if you get outside of the FQHC world and you get out there into the world of, primary care where patients are mostly from commercial insurance, vast majority of primary care providers don't have this, and so hence the need to just really for us to be thinking outside of not only the CFHA. CFHA is an amazing resource and is doing fantastic work. But how do we reach people who aren't in CFHA, right? Including even lots of people who are doing, who are professionals like us, who are doing integrated uh, care but aren't in CFHA, or are primary care providers who don't have integrated care. So anyway, hence the whole thing that Patty's mentioning here about speak to your doctor and kind of trying to generate public awareness about integrated care.
Yeah, just back to the overview. Uh, there's three more parts. So we talked about part one, two, and three. And part three, again, was the competencies, but part four is really about the role of behavioral health consultation. This is pretty different, because you're seeing both mental health and medical concerns. You're working as a consultant rather than a therapist, and you're trying to be accessible immediately to a lot of people. Um, and then I sorry, got distracted. Something going here in the place where I'm going on, where the place where I'm staying. But yeah, what do you do when you get in the room to create the big changes that people want and need in their life? And we really get into that in part four of the book. Uh, Chapters 7 and 8 are lots of details about how to make this consultation role work. And there's a startup checklist that's updated to modern times. Of course, we're constantly evolving. But these are available in Word version, so you can take like the startup checklist and modify it for your clinic system and put in exactly what you want to say. But it's week by week, and it really continues on for the first year of practice, which is what we're finding is it's really 6 to 12 months before people are confident and skilled and really doing this job in a way that they can then start to teach other people. And that's what we're going to be challenged to do as we scale up in the commercial world, from that 19% that Jeff was talking about. What do we do, though, to create this big, powerful change? Chapter 9 goes into detail about focused acceptance and commitment therapy. There's also a section on cognitive behavioral therapy, and there's kind of a matrix of use this for that, which makes it very easy. There's a toolkit for FACT in the appendices. There's lots of CBT and FACT handouts, one-pagers in the appendices. They're also on the website, um, free downloads. Then maybe the most exciting part of the book for me in a way was part 5, and writing about the advanced behavioral health consultant role and what their responsibilities are, because these are the leaders of tomorrow. They're evolving the model, they're seeing the opportunities, and they're working together. So in this chapter, we try to create a structure that they can work from. This includes offering slides that they can use in a foundation training for behavioral health consultants and other people on the team, as well as tools that they can use to assess level of integration in individual clinics over time. We also have a new tool in there that I really have found useful in Scale Up in New Zealand called the Gather a reflection and planning tool, which is something that clinical supervisors can use on a weekly or monthly basis with new groups of behavioral health consultants that are just coming into this role. Um, we have a day in the life of an advanced behavioral health consultant that I think really helps one to think about pathways and group services in a new way. And that's something we really need to be doing more and more. Part four, working the puzzles of integrated care. I think was a lot of fun to write. It's what we're asked a lot, our most frequently asked questions. And the last chapter of the book is top 10 tips for implementers. Jeff's going to go into detail about that momentarily, so I won't say more about it. I will say this is the link where you can order the book, and if you put in that code, SPRAUT, then you get 20% off, which always helps. The book is available as an ebook. It's available if you just want to buy a chapter, maybe you're interested in the top 10 tips. There's a lot of free materials. You don't even have to buy the book. Just explore the website. Jeff and I also, with the help of some of our buddies, created some videos, which I think we tried to choose some things that we find people struggling with when they're teaching core competencies. So a little bit of a video clip to supplement training efforts. And um, the Speak to Your Doctor um, half sheet, the first half of the sheet is for patients. And you can modify this. Again, we put our stuff at PDF sometimes just to save space and so you can move them around, but they're available in Word too, so you can, kind of look at what you would like to have or talk with, talk with your parents, your family. What would they like to have and what would they want to have on a sheet if they were going to have a conversation with the doctor? So you want to encourage people to say what they like about primary care. That's something people in primary care need to hear these days. And then say what you want, what would make it better for you. So, practical things that we would say, not as healthcare providers, but just as human beings. And indeed, we are. Like, I would like, it would be great if my family member had someone to talk with about their use of alcohol in addition to you, someone to talk about. Or I think new parents would benefit from being able to talk with a staff member trained to help with behavior problems and just day-to-day parenting when they come in for well child visits. So very practical descriptions of problems of living that people would love to see as part of their primary care service. Third thing is ask what you can do. So in that conversation with your doctor, how can I help make this a reality in our community? What do you think I might be able to do? Now, the second half of the tip sheet is some ideas for doctors and other primary care providers. So things like talk with your clinic manager, talk with others in professional or associations, talk with each other, form a clinic committee. Of course, read the book, get the free chapter at the website, and pass it along to people. Get that conversation going. And yeah, so this is modifiable, a one pager. People can print out, put it in your holiday card. You can make a difference in your community. I also wanted to quickly, before I sign off, say that their CFHA is going to offer a focused course in March 2026. The first class will be on March 18th. Tried to pick a time that would work for people on the East Coast or the West Coast in the in-betweens. It involves 7 consecutive weekly 2.5 hour Zoom meetings. And this is the link to the registration. Just a little bit more about the course. It's really actually 2 courses. The first course has these titles for the individual webinars. It's very practical, very experiential, lots of worksheets. You'll have a course manual. You'll learn about psychological flexibility, moving toward what matters, relating differently to what hurts. A lot of things hurt in life, and how can we relate to them differently? Um, Being able to work more in the present moment is so energizing to our work as BHCs. So I'm really looking forward to teaching about the fairy dust of this approach and giving some tips on how to work in the present moment. We'll talk about the flow of fact and also fact practice competencies. So we have a competency tool, 17 competencies. The last webinar is all about assessing where you are on these competencies and creating a learning plan for yourself. Course 2, which will probably start late in 2026, is for graduates that have been out there, graduates of course 1 that have been out there practicing and honing their skills. It's called Mastery, Focused Acceptance and Commitment Therapy. And here, the learners will be working with metaphors, and metaphors are so much fun to work with. Um, and more on present moment. They'll also receive a copy of a manual for delivering the Fact Life Path class. It's an excellent generalist kind of class to offer in primary care for people that have a wide variety of problems. I'm working with a group in Norway right now, and they have life path classes for people diagnosed with cancer, with chronic fatigue, with chronic conditions of all kinds, such as diabetes. Um, so a very useful class, which can also be offered as a class for families with children, and just learning the psychological flexibility that their family needs to travel through their lives. So I'll help people kind of identify their target population and then plan and evaluation plan and make adaptations to the manual. So um, we'll also be working towards getting everybody up to the excellent area in the fact core competencies, and we're beginning to help people teach fact to using materials from the first course. So being able to teach it to colleagues, teach it to early professionals, teach it to people that are undergraduates or graduate students, and also teach it to community support workers. Indeed, it's a flexible approach and one that we can adjust. With that, I'm just going to say, oh, one other thing I did want to tell you about, in case you're interested. I'm doing a couple of full day workshops on fact with diabetes and chronic pain in March in Philadelphia, and there'll be watch parties, but hybrid in Philadelphia. So I know diabetes and chronic pain looms large right now, so I wanted you all to know about that. And with that, I'm going to turn it over to Jeff so that he can uh, address your questions and comments and share more about these tips. So thank you so much for your time today. And I just have to hop on to another meeting that I couldn't move around. So I wish you a joyful holiday with your family, your friends, that you get outside and see beautiful things, look up. Thank you. Jeff, you got the slides up, so I'll stop share.
Yes, I will. I'll put the slides up here. Okay, thanks, Patty. I know you got to go, but
Yeah.
thanks for all that. Okay. All right. And I will, yeah, I'll jump in here with just going through our kind of highlights of this chapter 14 in the book. But uh, but and then, yeah, thanks for to those of you who were playing along with guessing there in the chat box. But I I just happened to be doing some recently, some research on this topic of like, how widespread is integrated care, how widespread is PCBH, and that sort of a thing. Uh, it's so uh, difficult sometimes because if you're in CFHA, it kind of seems like everybody's doing integrated care, because everybody that you know is doing it. And yet, it's just the vast majority of folks out there, both clinicians in primary care and patients who go to primary care, don't have this kind of service in their clinics. So, well, let me pause just for a moment before I jump into this slide. See any comments, questions, thoughts about anything we've been talking about that people would want to bring up here? Okay. And obviously, if you have anything and you want to put it in the chat box, that's great too. But um, I think with the time we have left, maybe what I'll do is I'm going to run fairly quickly through our top 10 tips. It's actually going to be our top 9 tips because the one that's there for tip number 4 is not correct, and I'm forgetting what that actually is supposed to be. So just going to do 9, and then I'm going to have to go back and read the book to remind myself of what tip number 4 was. But I'm going to run through these fairly quickly, and then I'd love to hear from you all. Does this feel like it's on target, uh, from your experience doing integrated care, or what might be in your top 10 list that we haven't included here? Because this list is just sort of our anecdotal, based on Patty and my anecdotal experience, right, of helping systems integrate. Although, mixed in there are certainly empirical findings too. But so the first tip that we talk about in the book for implementing is for clinics to know what they want, right? Because there are different ways of integrating, and if and what PCBH is primarily about is about access. That's our primary goal with PCBH, is just to reach more people, um, and in the process to also make primary care better for everybody as well. Not only for the people who have behavioral health concerns, but really for everybody that goes to that particular clinic. That's our goal. So, but a different system might have a different goal. Maybe their main goal is to improve their depression outcomes or their anxiety outcomes, or their outcomes with a specific condition. A collaborative care approach might make more sense for them. Um, uh, other clinics, maybe they want more specialty care, in their clinic, and they want to go with more of a co-located approach. So I think the first, important tip though for systems and to think about is just what do we want. Um, Second is to give clear guidance. So uh, we see this all the time that people get hired into primary care and they really haven't gotten any training and usually I'm talking about behavioral health providers here, get hired into primary care to do integrated care work and haven't been given any training or guidance on how to do it. There's just sort of an expectation that they're going to know what to do, and they don't, right? So having clear training protocols in place for folks, resources to get them up to speed with integrated care. Assume that they don't know what you want them to know in order to work effectively in your integrated care system. But and don't forget about also educating the team and giving them clear guidance too about what you're trying to get out of integrated care. Because certainly, you know, there are plenty of people on the medical team too who've not had integrated care experience. Measure twice, cut once refers to just so often I see systems that uh, everybody knows data is important and they want to be able to make data-driven decisions about whether it's about hiring or staffing or workflows or priorities. But so many people, when they're building their integrated care service, they wait until later to develop all their metrics. And I really encourage systems to, put the metrics first, right? Because it also helps you to think about your goals for this new integrated care service. So developing all the metrics that you want to be tracking on your new integrated care efforts can be helpful. Like I say, number four is going to have to remain a surprise because that's not correct there. Number five, be flexible. You know, one of the things that I'm reminded of all the time being in primary care is that I'm a psychologist in my training to be a psychologist. Flexibility was never part of my training. Like to the opposite, right? It was the emphasis was on boundary setting with patients, right? You always want to start your visits on time. You don't want to give less time than planned to a patient. You don't want to give more time than planned to a patient. You definitely don't want to be interrupted. Uh, you need to be planning your therapy out with the patients before you start jumping into anything. Um, so a traditional therapy approach is no one would describe it as flexible, right? Come into primary care though, where you're working on the front lines of primary care, and it's the complete opposite, right? At least if you're doing PCBH work, you're being asked to accept interruptions during your visit sometimes. You're being asked to see people with all different sorts of visit links. Because you're working people in, you're often not starting on time or ending on time. And something's always going wrong. The EHR is not, stopped working for some unknowable reason, or team members didn't show up today, MAs that are crucial for you. So your flexibility is, part and parcel of doing good work in PCBH, but it is not at all how we're trained in mental health. So being flexible is just developing that is really it's I mean it's a skill. Thinking like primary care, you know, long time ago we were bouncing around ideas for this model. What's the right name for doing this kind of new work that we're doing and so forth, and became apparent that well, really what we're talking about is having behavioral health providers practice like primary care providers. That's really what we're talking about here. We're talking about having behavioral health providers embrace the goals and the functions and the strategies of primary care instead of the goals and strategies that that are typical of a more specialty mental health approach. So, in order to do that and do it well, you have to understand what primary care, what are the goals in primary care, right? And what are the functions and the way that they practice? What is the culture there? So being able to think like primary care is really crucial to doing this work. Um, Seizing the moment, this is another thing where the traditional mental health therapy training approach is is a much more what I call it, think of as a passive approach to people getting care, right? So there's no urgency to it, right? The idea is this is going to be a long-term problem that we're going to be tackling for, the weeks, months, years to come. So we're gonna. There's no rush here. I know you'd like to see me as a therapist, but let's get you scheduled for an initial kind of orientation call to see if we're going to be a good match for each other. And then let's, after that, let's get you set up for an intake if it looks like we're going to be good to work together. And that intake might take a couple visits. We'll plan everything that we're going to do. And then we'll get you going maybe a couple weeks after that on your therapy appointment. Right? Weeks or months down the road from when the person's actually looking for care. That works fine for some people, right? If you've got patients who are more psychologically minded, more motivated, they're more, kind of ready to engage in some mental health care, that can work fine. But your typical primary care patient, that doesn't work for, right? Your typical patient who's coming into primary care, whose health is being affected by behavior or emotions in some way, uh, they're not going to wade through all of those steps and wait all of those weeks to get into long-term therapy with somebody. They kind of got a problem. They want to get some idea about what to do about it now and get something going for it. So seizing the moment. So often I see behavioral health providers when they're in primary care, they've got a patient who, is a warm handoff that was given to them. They've got an opportunity to have a visit with that patient right now, but maybe they've only got 15 minutes or something like that, and they don't feel like that's enough time. And so they meet the patient, give them their card, flash them a smile, and get them scheduled for a full 30-minute visit sometime down the road, right? To which many times the patient doesn't show, right? So, so it's so important just to really seize the moment and see patients when you have them in front of you and be flexible, right? If you don't have the normal amount of time that you used to have, and that's okay. You can work with what you got, but that's another key part of being successful here. Number 8, tend to your template. So I'll tell you right now, no such thing as a universally perfect template. I'm talking about a schedule template here, appointment template, right? For behavioral health consultants. No such thing as a one size fits all or perfect template. Um, but it is important to be attentive to how your template is built for your BHCs, because what I see so often is that the templates are kind of causing problems. Uh, I was just talking with the system the other day who has like a really high no-show rate for their BHCs, like 70% or something like that. And their patients can't get in uh, you know, for weeks at a time. And if you look at how their templates are built, they blocked off all of this time, right? So like this, 8 o'clock to 11 o'clock on Mondays and Wednesdays are for walk-ins, 1 o'clock to 3 o'clock on Fridays is for uh, hospital discharges, to get them. New patients are, from 2 to 4 every day, that sort of a thing. And it's like, well, I can tell you right now why nobody can get in to see you for long periods of time, because there's they've got to fit into just the right window there. And secondly, I can tell you why there so many people are not showing up for appointments, because they're kind of getting forced into appointment times that aren't really good for them, right? So making sure that you have a template that works for everybody is crucial. Tip number 9 is leave the diagnosis at the door. I mean, we were all, uh, I'm going to guess, trained that kind of the way you as a therapist, the way you approach care is you do your intake, you gather the volumes of information on the patient, you make a diagnosis, and then you set about your work doing therapy with the patient. Um, but that creates, if you try to do that in primary care, well, it creates problems in specialty care too. But especially if you do it in primary care, it's going to create all sorts of problems. Um, and one of the problems it creates is that when people have a end up with a diagnosis uh, that BHCs feel like is too going to be too complicated or complex, for them to address there in primary care. There's a sort of a reaction where they want to just refer the patient out to specialty care, right? The problem is we can't really predict who's going to improve in primary care, right? A diagnosis doesn't tell you anything. I'm sure you've all had this experience, or lots of patients with, they've got a problem list a mile long, they've been in multiple hospitalizations, and you see them, and after a couple of visits, it's remarkable how they're making some great changes, you know? Or by contrast, you have people who have a pretty minimal mental health history, and they seem to just really struggle. We can't predict who's going to do well. So I really encourage people to just jump in and try to help and see what happens. And part of that involves believing in the power of primary care, which is the final tip there. Um, if you think about what primary care has in terms of resources, and you compare that to a typical therapy office, like it's not a competition. Hands down, primary care wins that competition in terms of the types of services they can offer, the type of care they can offer. You've got a multidisciplinary team. You've got in many cases, you've got a care support staff, disease managers, care navigators, that sort of a thing. Uh, you've got a team that in many cases knows patients, maybe even knows their kids, their families. In some cases, has maybe known them for years. It's a place where the people trust. You've got access to the EHR, where you can see what's going on in other aspects of the patient's care. You know what's going on. If they're going to specialists, in neurology, you know what's going on with neurology, right? You're maybe even talking to the neurologist. If a person goes to a typical therapy office, they get none of that, right? They get a therapist. So I think it's really important for us to believe that we can do incredible work in primary care if we have well-supported teams that people like us are a part of, um, and we're really practicing in a way where care is super accessible to patients. There's an amazing amount we can do in primary care. So anyway, I'll leave it at that with our last 8 minutes here or so. Be happy just to open it up to thoughts that folks have on, you know, what's a top tip that you would have that isn't on our list here, or what do you disagree with, or questions, or any other topic. It doesn't have to be about this top 10 list either.
Jeff, could I just emphasize something that you said? Just so others know, I'm a primary care doc, not a therapist, and have lots of years of experience and stuff. And Jeff and I know each other a bit. Um, you had said one of the first things you said is make the practice better. That's part of the goal. Some of the practices want that. When I was in training, we had a full-time psychologist in our resident practice, and it changed the character of the practice having that person there. So what I would say, and I've been in a lot of different types of practices over the years, it seemed very important for that person to act like and feel like part of the practice. And I say that because sometimes there's an aloofness or a distance, even in nice people that want to work together, they feel like part of the team,
Mm-hmm.
but like go to lunch with people, go walk around, say hi.
Mm-hmm.
This is not nothing.
Mm-hmm.
And I think it changes the character and it gets people, especially if you banter with them about a patient, it changes how they approach things. Anyway, I won't belabor it, but I thought your point was well made, and I think that's something to remember.
I 100% agree, I mean, that's part of being on a team, right? Whether
Yep.
you're on a basketball team or I was just hearing a basketball player interviewed the other day, and that they were asking, the interviewer was asking him, well, what makes your team so great? And he was saying, oh, we're, you know, we're friends. I mean, we do stuff together off the court, and on the court. And so I think that speaks to your point. Any kind of team that you're on doesn't mean you have to be buddy buddy and best friends with everybody, but just, being social and showing that you want to be part of the team and that you're trying to get to know people in different ways goes a huge way. I 100% agree. I'm going to stop sharing and check for some reason I couldn't see the chat box there. Uh, let's see. Oh, I have a question here. What would you have called it if you were to name the approach today? Oh, same thing, Maria. Yeah, same thing. I mean, at least in my mind, it captures it perfectly. What we're doing, that at least the way that I think of PCBH, if I could summarize it, it's about it's about practicing behavioral health in a way that mirrors the goals and the functions and the strategies of primary care. So it's primary care, behavioral health, um, and so yeah, I'm happy with how it came out. I don't know what other ideas people might have. Um, let's see. If anybody has other ideas, by the way, for a different name for this work that we do, I am interested in hearing that too, just out of curiosity. But I think that captures it for me. And then Maggie asked, in general, do you see faster uptake of PCBH by smaller primary care practices or larger healthcare systems? That's an interesting question. I mean, in I guess it depends on maybe a little bit about what you mean by faster uptake. If you mean like is there more interest in one versus the other, or versus like how quickly does it get rolled out? But if we're kind of talking about the latter, like I might go with smaller, and I don't know. Again, I'm curious to hear what other people think too in your experience, but uh, to the point we're just talking about, I think it's easier to build teams when you're in smaller clinics. But, I think just so much of it depends on leadership and how much support you have. Because I know the first system that I worked in where I spent most of my time was in FQHC out in Seattle. And when I joined, it was not that big. Now it's actually pretty big, but when I joined, it wasn't that big, and it really felt like having that intimacy, there of the smaller system was really so helpful for building it. But then later, I went to a much, much larger medical system that was primarily uh, private insurance, was not an FQHC, private, mostly commercial payers. Um, and they had nothing to start with. And in about a year and a half, we built integrated care into around about 20 clinics. I mean, it was like bing, bang, boom. Part of it was I knew what I was doing then, where I didn't when I first started. But so I don't know. I think it can go either way. But what made it so hugely helpful in both cases was just that forging connections with leadership, and so that they're really fully on board, and you're getting everybody talking about this. And yeah, seeing your comment here, you were referring to initial interest in buy-in. You can see pros and cons. Yeah, I really think it just depends, on you could certainly I've certainly seen small systems that are struggling with their integrated care efforts, where there just isn't the mojo there for it, But if you've got leadership and some champions on the primary care side who really want to do this, I think that's just invaluable. But, can see it either way. Yeah, thanks for the question. Well, any other final thoughts here? I guess we got about a minute left or so. Really appreciate everybody sticking around. Um, all right. Well, I know Khadija had to leave, so maybe it's on me to excuse the class. I don't know, but uh, so is there anyone from the SIG or oh, Hannah's here. Hannah, did you have any thing you wanted to say to end here?
I don't have anything additional, but thank you so much, Jeff, for being here and sharing with us today. This was a really great meeting.
Great. All right. Well, happy holidays, everybody. Thanks again for sticking around and for your comments.
Thank you.
All right, bye-bye.
Thank you.